And our next speaker is Dr. Donn Colby, who actually is the one who founded the PrEP 15, at that time PrEP 30 service at the Thai Red Cross Anonymous Clinic. And Donn is a clinical research physician who is now based in US, but who used to work and based in Thailand at the research unit of the Thai Red Cross AIDS Research Center for many years. He will be talking about the perils of PrEP, STI, and resistance.
Okay, thank you for that introduction. So just to start out, first I think just need to mention the benefits of PrEP. I think we all know already, but just to keep in mind when we're talking about the risks and benefits, PrEP is extremely effective at preventing HIV. It's the most effective thing that we've come up with in the 30 years of the epidemic. If PrEP is taken every day, regularly, it's more than 99% effective at preventing HIV, and we know that it works across all high-risk populations. As mentioned already in the last couple of talks, in cities that have both implemented PrEP with a very high degree of coverage and have good systems for evaluating the effects of PrEP and evaluating new HIV infections, they see dramatic decreases in HIV infection. So we've already mentioned San Francisco, Sydney in Australia, and London, where PrEP has decreased 30 to 50% just within a few years. So we know PrEP is very, very effective. But of course, like any medicine that we use, it has some side effects and some risks associated as well. So in this talk, I'm going to focus on two risks. One is STIs, we've heard a little bit about before this morning, and also HIV resistance. So first, STIs. So the concept of risk compensation comes up when we're talking about STIs with risk, with PrEP. So risk compensation means that if somebody has some behavior and they have a perception that the risk of that behavior or the risk of the consequences of that behavior have decreased, that might actually increase the behavior, and in the end they might actually end up with more risk than they had before. In the context of PrEP, this specifically refers to the fact that if people think that the PrEP is protecting them from HIV, they may then in fact have more risky sexual behavior. So may be less likely to use condoms, and as a result of that, may be more likely to get STIs. So first, in terms of the randomized controlled trials that showed us that PrEP was efficacious, they were thinking about risk compensation and the possibility of this when they designed those trials. So they wrote it into the trials to look for that. And actually, within the big randomized controlled trials that showed us that PrEP had good efficacy, they did not see any risk compensation at all. So you can see that the trials that were there, and in the trials that specifically looked for STIs as well, they did not see any increase in STIs from before people took PrEP until after. But of course, those are randomized controlled trials. It's an idealized situation. People are getting a lot more counseling, free condoms. They often have very frequent visits, maybe once a month or so. So it's very, very intense counseling that's going along with the PrEP delivery, and it may not be representative of what happens in the real world. So we actually do have some data, just that's come out very recently, from community-based PrEP programs on what happens in terms of risk compensation, in terms of condomless sex, and in terms of STI rates. And there, the data is a little bit more mixed, but it really does fall into the side, I think, now, to show us that it's probably true, that there is some risk compensation, and that most places, when they look at it, they do find that condom use does go down after people start PrEP, and the STI rates do go up, although modestly. They might go up by 10% or 20% in all. Of course, the major caveat is all this data comes from Western countries and mainly from MSM populations. So we just don't have as much data from developing countries or from other high-risk populations. There was a nice meta-analysis that came out just a couple of months ago where they took all these studies that looked at things like condomless sex and STI rates before and after starting PrEP and put into a meta-analysis. And a couple of things that they found. So one was that the STI prevalence pre-PrEP, so before people start PrEP, was very, very high. So about 25% of people had an STI before they ever started PrEP. So this makes sense because people, by definition, who are starting PrEP, they have high-risk behavior. We know they're having condomless sex. We know they're having multiple sexual partners. In many places, an STI is a criteria for starting PrEP. So by definition, many people who start PrEP already have an STI. So that we know, very high rates of STI even before people start PrEP. But then they do show that after people start PrEP, the incidence of STIs is also very high. So in this meta-analysis, they had, you can see the bottom row there, 11 studies, more than 6,000 participants. The incidence of STIs was 72 per 100-person year. So that's very high. Almost 3/4 of people are getting an STI at one point in the first year. But in this meta-analysis, I mean, there was a couple of caveats. One, again, most of these studies are coming from MSM population in high-income countries, because that's where the data is, and at least the published data. And they said there really is not enough data for this to do a meta-analysis to see any change from before PrEP to after PrEP, and that's basically because in very, very few places are we doing regular STI screening on MSM who are HIV negative and not on PrEP, because those people are not coming every 3 months for an STI test, or even every 6 months or every 1 year. So it's only after people start PrEP that we have them come back on a regular basis, usually every 3 months, and they're doing STI testing every 3 months or 6 months or 12 months. So there just isn't enough data at this point to do this kind of analysis looking at pre-PrEP and post-PrEP in the same population. So just to summarize on PrEP and STIs, so we know that PrEP users have a very high risk for STIs before ever starting PrEP. And there's actually good data that condom use rates were decreasing, and STI rates were actually increasing in MSM populations before PrEP ever came around. So some of this may be just continuing trends that were happening even before we had PrEP. But the data that I've looked at and I think is out there does show that there probably is a small increase in STI rates after people start PrEP, at least in MSM in high-income countries where we have the data. There are some modeling studies that show that there's actually a potential to decrease STI rates in the community by starting PrEP. And why should that be? Well, that should be because, as I said before, people who are not on PrEP and do not have HIV are not coming regularly into our clinics, so they're not getting tested regularly, and they may have an STI for a long time before it becomes symptomatic and before it gets treated. And actually, by getting people into PrEP, we force them to come back on a regular basis, usually every 3 months, where they are screened, maybe clinically, maybe laboratory, for STIs. We can diagnose the STIs earlier and treat them earlier, and that may actually, in the end, lead to a lower rate of STIs in the community. And then the WHO actually sees PrEP as an opportunity to bring increased attention and resources to STI screening, so we can do more screening more often and for more people, and then actually may be able to actually decrease STI rates through PrEP services. So now I'll move on to HIV resistance. So in terms of resistance and PrEP use, there's three ways or 3 time points at which somebody who is taking PrEP can be at risk for resistance. So the first one is that it's possible that somebody could actually have HIV before they start PrEP. Of course, we screen for an HIV test before starting PrEP, and we try to avoid this. But we all know that there's a window period between the time that somebody becomes infected with HIV and the HIV antibody test becomes positive. That window period can be 2 to 4 weeks. And if somebody comes in for a PrEP service at that time, they may have a negative antibody test. They may meet all the criteria for PrEP and actually start PrEP, but in fact, they have acute HIV infection. It just hasn't been detected. yet. So that's one way. That's very uncommon. I'll show you some numbers, but it's much less than 1% for people starting PrEP. But that carries a moderate degree of risk for HIV resistance, because we know that giving 2-drug PrEP for somebody with HIV infection is not going to be adequate for treating the HIV, and is going to lead to a very high chance for resistance. But the second way is that people can actually acquire HIV infection after starting PrEP. And there's 2 scenarios for that. So one is, as we saw in the last talk, retention in PrEP is not always very good, or adherence to the drugs is not always very good as well. And we often see people who are on PrEP, they take PrEP and they stop. Maybe they stop for a day or 2, maybe they stop for a week or 2, and they start again, and they kind of have these cycles of stopping and starting, maybe related to their risk behavior, maybe related to other things as well. But if there's a period where someone is taking PrEP with not very good adherence, so less than about 4 pills per week for MSM, which we know is highly effective, or if they have a period where they stop PrEP and then have exposure, they can become infected with HIV. That's a wild-type virus. The virus does not have resistance to the PrEP drugs, but the person's just not taking the drugs, or taking it with adherence that's too low to be effective. And then the last one, that's possible is we know that the HIV virus does have resistance to drugs. So it's possible that if there's a virus out there that is already resistant to the PrEP drugs, FTC and TDF, that then if somebody on PrEP with good adherence, taking it every day, is exposed to a virus that's already resistant to the PrEP drugs, then the PrEP drug may not protect them in that scenario. That is extremely, extremely rare. In the next slide, I'll show you exactly how many cases of that have been found in the world, and it's a very small number. So that one is probably the thing people worry about the most, but actually is the least likely to actually happen. So I'm going to go looking at that list we just looked at in the last slide. I'm going to start at the bottom and go to the top. So the bottom, you remember, was transmission of HIV in somebody who's taking PrEP with good adherence. So that means that the virus may be resistant to the PrEP drugs already, or in some cases, no resistance that we can see. But there's been exactly 6 cases of this in the entire world since PrEP came out over about 8 or 9 years ago. So out of hundreds of thousands, maybe even millions of people who've taken PrEP in the world already, only 6 cases where somebody's actually taking PrEP with good adherence and gets HIV. In most of these cases, the virus does have some pre-existing resistance to HIV that we can determine by genotype testing. Only one of these 6 cases was a case in Amsterdam, came out a couple of years ago, where there was no resistance that could be found in the virus, in the genotype at all. But this person also had something like 50 or 100 sexual partners per month for many, many months in a row, condomless receptive anal intercourse with several people per day, again for months at a time, and not quite sure, maybe there were some STIs involved there as well, but that was a very special case. So let's, going back to that table, going up one, now we're going to talk about people who start PrEP, do not have HIV, start PrEP, and at some point in the future become HIV positive. So this is actually an abstract that came out in the R4P conference 2 years ago, where they did a bunch of studies, demonstration projects, with a total of 10,000 people in all these projects, and they came out with 91 people who had become HIV positive. Again, since these are mostly high-risk MSM, normally the incidence rates we see in Bangkok or in most other big cities with MSM are 5 to 10%. So out of 10,000 people without PrEP, we might expect 500 or 1,000 to get HIV. But in fact, in these projects, only 91 people got HIV. You can see that of those, about a third, 27, hadn't taken PrEP within the last 30 days of getting HIV. So obviously, they stopped PrEP, had exposure, and then became HIV positive. And then the other people who supposedly were taking PrEP, in some of them they were able to do dry blood spots, to actually look how much PrEP drug was in the blood of these people, and what is that level compared to what we think their adherence was. You can see actually that of these people, they could do the drug levels. 98% of them were taking PrEP, either not taking it at all or taking it at less than 4 pills per week, taking it less than the level that should be efficacious. So really the lesson is that if somebody is given a prescription for PrEP and at some point in the future comes back and has a positive HIV test, the most likely scenario, 90% of the time, is they're just not taking, either they stop taking it or they're taking it less than 4 pills per week where it's not going to be effective. And then there is some data you can see on resistance below. So higher, for this group, a higher rate of resistance to emtricitabine, 8 participants, and then tenofovir resistance was very uncommon, only 1. So you can see it's a very big, many programs, large number of people is 10,000. The people who end up resistance in the end is a very, very small number. And then finally, the last scenario I talked about, which is one that I think we see a fair deal of and has probably a little higher rate for causing resistance, or probably the scenario that's going to be the source of resistance in PrEP programs that we see the most, is people who start PrEP when they have acute infection. So we do have some data. I'm going to show you from the RCTs and then also some data from here at the Thai Red Cross in the next slides. But this was a meta-analysis looking at all the different RCTs for PrEP efficacy. So you can see there was 12 trials there, over 21,000 people in these trials. And because these are clinical trials, they do viral loads on everybody when they start. Maybe not done when it starts, but they do retrospectively at the end of the trial, so they know who has HIV at the beginning of the trial. So the number is quite small. Out of that 21,000 people, there were 77. There was about 1 out of 280 people who were in acute HIV infection when they started PrEP. Again, these PrEP trials are recruiting high-risk people, so that 1 out of 280 is not too far out of line with what actually we see in our cohorts here in Bangkok. Now, because these were RCTs and a lot of them had placebo arms, some of those people were randomized to placebo, so they were never exposed to PrEP and didn't have any risk for HIV resistance due to the PrEP. But there were 56 people randomized to TDF or FTC, and we can see that again, the risk for the FTC resistance was higher. 15 people ended up with FTC resistance, and then a smaller number, 3, came out with TDF resistance. So here we are, in the end, we have 18 people who had resistance because of exposure to PrEP, but this is out of 21,000 people who started PrEP, 21,000 people with very, very high risk for HIV, and we would expect probably 1,000 or 2,000 HIV infections in these people if they had not been on PrEP. And finally, some data from the Anonymous Clinic here in Thailand. This again comes from the PrEP 30 and now PrEP 15 program, looking at data from 2014 to 2018. And in that time period, there was 2,442 people who started PrEP. So they all had a negative antibody test. But we found out that actually 7 of these, or 1 out of 350, had acute HIV infection when they started PrEP. We're able to determine that at the Thai Red Cross because we have another study of acute HIV infection that screens all the negative antibody samples for HIV RNA to diagnose acute infection. That screening of RNA, it takes 1, 2, 3 days to get the results, and we give PrEP same day. So these people who came in, they have the criteria to start PrEP, they have a negative antibody test, we do same day PrEP, they start PrEP, but after 1 to 3 days, we get a result back from the lab says, oh, their HIV RNA was positive before they started PrEP. So some of these people took PrEP for just 2 or 3 days. Some people, you try to call them up and they don't answer, and it takes a week or 2 to get them. And there's a couple that actually didn't come back for a month or 2 months for reasons I could talk about separately. But we were actually able to do genotype tests on all these people who started PrEP during acute HIV infection. And we found that 3 out of 7, so 43%, had FTC resistance, either the M184I or V mutation, and we found none of our cases had TDF resistance. And we also showed, too, that the risk for resistance was correlated very well with the time they were on PrEP. As I said, it took some people, we were able to call them the next day, and they came back. We stopped the PrEP, started ART, but other people it took a month, or in one case, 4 months for that person to come back. And we really could show that if somebody took PrEP for 15 days or less, that we found no resistance in those people, but people who were on PrEP for 4 weeks or more had a higher risk for FTC resistance. So just to summarize the resistance, you know, in the end, it's a very, very low rate of HIV resistance after PrEP use. There's actually models out there looking at, you know, how does resistance develop from PrEP or ART, and really coming up with the vast majority, 95% of resistance in the community is from ART use. It's not from PrEP. Most HIV infections occur after PrEP is stopped, and in that scenario, there's very, very little risk for resistance. The greatest risk, I think, that we're going to see in any of our programs where we're doing PrEP, the greatest risk for resistance is going to be people who have HIV infection when they start, but their antibody test is not positive yet. That risk for resistance can be minimized if we can identify the acute infection and switch people to a 3-drug ART. Within about 2 weeks of starting PrEP, that the risk for resistance is going to be very, very low. We also have to realize, too, that the greatest frequency of resistance mutations that we see in PrEP use is the M184I or V mutation, and that one really doesn't have any effect on our first-line drug treatment, so it's not really going to affect ART anyway. So in terms of minimizing the risks associated with the PrEP, for STIs, I think we need to screen regularly, treat early, and focus on counseling. And in terms of the drug resistance, we should be screening. I think everybody's doing screening for acute HIV infection before starting PrEP. Some of that can be clinical, which you can do everywhere. Laboratory is available as well, but that's more resource intensive. And I think because we're sort of out of time, I'm going to skip this one and just go to the end and just talk about, just as I was thinking about, all risk needs to be taken in perspective and in relation to all the other risks that we all face. If you saw me limping, that's because this is my x-ray that I did yesterday in Ho Chi Minh City after a motorcycle accident. And I can say, as somebody who both takes PrEP and occasionally drives a motorcycle in Southeast Asia, the risk from the traffic in Asia is to me, much higher than any risk that's ever going to happen from PrEP. So with that, I'll say thank you.